Hello, and welcome to this Clinical Care Options Hematology podcast. I'm your host, Jervis Constanzo. In today's episode, we're joined by Dr. Eunice Wang from Roswell Park Comprehensive Cancer Center in Buffalo, New York, and Dr. Courtney DiNardo at MD Anderson Cancer Center in Houston, Texas. Together, they will be discussing key clinical highlights and takeaways from studies in acute myeloid leukemia, AML, that were presented at the 2024 ASCO annual meeting in Chicago, Illinois, and the EHA 2024 Congress in Madrid, Spain. This episode is part of a larger educational program entitled Congress to Clinic, Myeloid Malignancies Clinical Advances Journal Club on Emerging MPN, MDS, and AML data. For more information on Drs. Wang and DiNardo, along with a link to the complete program, including downloadable slide sets and clinical commentaries, please visit the show notes for this episode. Now let's hear what the experts have to say on data presented for AML at the 2024 ASCO and EHA conferences.
I'm looking forward to presenting updates from the ASCO and EHA meetings on acute myeloid leukemia. So there are many trials to discuss, and I'll try to do this very briefly, but many of them focus on new and improved regimens, both with and without targeted therapies. And as we know, we've been blessed over the last few years to have many new drugs approved for this disease. And we are increasingly aware that this is not just one disease, but a constellation of different biological subsets. And that's what makes all of these studies very challenging to summarize in just a few minutes. So I'd like to move forward with the first abstract from the meeting, which is actually by my colleagues and friends at MD Anderson. And this is looking at the efficacy of this FLAG-IDA venetoclax regimen, both in newly diagnosed or relapsed refractory AML. So this regimen has been one that's been piloted at MD Anderson and other medical centers. And this was just a composited and updated data presented previously of their summary of data to date on 68 patients, were primarily young, fit patients who were newly diagnosed with acute myeloid leukemia, who had relapsed and refractory disease with a limited number of prior therapies. This is not a regimen for necessarily older, unfit people. I want to highlight that now because the median age of treatment of these patients is 44 to 47, which is not necessarily the median age of presentation of AML, which is usually in the late 60s to 70s. You can see proportion of these patients were greater than or equal to the age of 60, but that only represented about 15% of patients. There were a significant number of patients, that 24%, that had second or therapy-related disease. And you can see here the division in the newly diagnosed population of patients that had favorable, intermediate, or adverse risk. Patients with relapsed refractory tended to be a little bit older, 25% refractory, 32% therapy second related, and about a third with prior transplantation. The overall response rate of all newly diagnosed patients with a CR rate of about 80% and an overall response rate, CR, CRI, CRh rate of 100%, upwards of that in the newly diagnosed population. The 13 patients that had favorable risk disease had an exceedingly good outcome, with 100% of CR, as well as the intermediate risk patients who had a CR rate of 80 to 85%. Patients with adverse ELN risk did not as well. And you can see here that primarily these patients that didn't do well tended to be the ones with what we know to be the poor prognostic risk factors. You can see relapsed refractory patients, definitely a drop off. And it really were the patients that had been heavily pretreated, were salvage 2+ or TP53-mutant disease, who continued to fare poorly with this regimen. Patients who were in salvage 1 or p53 wild type actually had overall response rates upwards of 70 to 80%, with about 55% of them achieving CR. On the right-hand side, you see the very favorable overall survival curves. Encouragingly, in this very young patient population of fit patients, the 30-day mortality was 0%, 60-day only 1%. And you can see that 78% of favorable risk patients, 80% of intermediate risk had a 2-year overall survival of 78 to 80%. And again, the adverse risk did drop off. And you can see that there again was a big drop off in terms of patients who had previous treatment in the relapsed refractory group or p53 mutant. You can see here that this was a fairly intense regimen with the addition of ven to intensive chemotherapy. And you can see the median time to count recovery in cycle 1 and cycle 2. However, we're fairly reasonable. We have 25 to 28 days for ANC and platelet recovery, 31 to 39 days in cycle 2 plus. And you can see, however, that although the survival rates were exceedingly good in patients with favorable risk disease, again, patients with relapsed refractory TP53 and MECOM disease did poorly. What about other therapies that look promising? In the older unfit patient population, certainly venetoclax azacitidine has been our standard since the pivotal VIALE-A trial. But are there ways to improve it? Since we know that one of the mutations that predicts for resistance to ven-aza is FLT3, there have been a number of triplet regimens incorporating FLT3 inhibitors into the upfront setting. And this was the latest trial, again, presented by colleagues at MD Anderson, looking at oral decitabine, cedazuridine, plus venetoclax, plus gilteritinib, this triplet in both newly diagnosed and relapsed refractory FLT3 mutant patients. Now, this data in a total of 26 patients, 84% of whom had seen prior HMA, demonstrated, again, very high response rates in patients with newly diagnosed disease, 86%, almost 50% in relapsed and refractory patients, and a duration of response, and particularly the newly diagnosed patients, that was not reached. Now, in the relapsed refractory setting, less successful, 7.6 months. So many of these patients in the relapsed refractory setting would need to go on to subsequent allogeneic stem cell transplantation in order to really truly benefit from this regimen. Now, again, this triplet regimen has been plagued by our myelosuppression. How long, for example, should we give venetoclax in these patients? So even in the upfront setting, and in the doublet setting, this has become a key therapeutic question for all of us who've used this regimen. And both this study and the next study is really going to be looking at this in further depth. You can see here that this triplet therapy, even when it was held at day 14 to day 21, because of evidence of cytoreduction or blast elimination in the bone marrow, was still associated with prolonged cytopenias. ANC recovery after cycle 1 varied from 38 to 48 days, with platelet recovery taking 26 to 38 days. So again, although this triplet regimen is leading to very high overall response rates, particularly in newly diagnosed patients, I think we are still looking at this being not a standard of care therapy until we can figure out how much ven in particular to give to these patients. Now, this retrospective study is looking at that exact questions. At one of the ASH meetings, the French group, which is a multi-center retrospective analysis of older unfit patients who were considered not eligible per the VIALE-A criteria to get standard ven-aza with the ven dose of 21 to 28 days, were instead treated at these centers with what we call a 7+7 regimen, 7 days of azacitidine and 7 days of ven. And this data on these 82 patients appeared to be similar to what we were achieving with standard ven HMA therapy. So again, the clinicians at MD Anderson were very interested, and they decided to perform a retrospective analysis comparing their data in 166 patients treated with 21 to 28 days of ven-aza with the results of this 7+7 retrospective analysis. And when you see summarized below is that this seemed to substantiate the fact that patients that got 7+7 had equivalent overall survival as well as event-free survival as patients that were getting the 21 to 28 days. Now, which patients benefited from the 21 to 28 days? So as we would expect, the patients that were more sensitive to ven benefited from getting more ven. And these included patients that had both NPM1 mutant disease as well as those that had IDH1, IDH2 mutant disease in the newly diagnosed setting. Patients that had TP53 mutant disease, which did not seem to be highly sensitive to ven, there was no difference in outcomes for whether you got 7 days of ven or whether you got 21 to 28 days of ven. So this just provides further credence to the use of shorter duration ven, particularly in those patients for whom they might not be fit enough even for ven-aza therapy. So overall, in general practice, we're starting to see a trend towards decreased aza-ven use in the majority of our patients who do not have NPM1 and IDH1, IDH2 disease. Now, in many of these patients, we know that they are not going to be cured with ven-aza-based therapy. So what do we do for these patients? And I think there's an increasing awareness over all of oncology. And we saw this in the overall theme of the ASCO 2024 meeting, focusing more on quality of life and other parameters aside from response rates and survival curves for our oncology patients. There is a focus now on looking at other aspects of oncology care beyond just response. And this was in line with that trend. This was a multi-center randomized phase 3 study that looked at 115 patients with AML and MDS who were newly diagnosed and were recommended to receive non-intensive chemotherapy. These patients were then randomized to participate in a trial where they could get standard of care therapy for their AML and MDS, usually involving HMA or HMA-ven-based therapy. And in addition, the experimental group would get monthly outpatient palliative care visits and twice weekly palliative visits during any hospitalizations. And what this randomized trial showed was that this intervention resulted in significantly improved timing and rates of discussion about quality of life and end-of-life care, that these patients tended to improve better functionality, they tended to have reduced hospitalizations, and they self-reported their quality of life to be improved over those patients that just received what we would call standard oncological care. Now, is this surprising? No. We would think that more interventions and more engagement, I personally think the more conversations that we're having, and these were just literally, they weren't doing anything for the patients. They weren't prescribing more medications. They weren't giving more growth factor. They were just providing more emotional support and earlier discussions about the outcomes of their oncological disease than the standard of care therapies. And so this is something that we need to really be moving forward with and has been demonstrated in a randomized controlled trial, which is really our standard for oncology therapy. So moving on, what are some of the advances that we see in targeted therapies or oral therapies for our patients? As we know, many of our patients are preferring oral therapies, particularly our older unfit patients. So we saw this result, 5-year follow-up for a novel IDH1 inhibitor, olutasidenib. Now, this is the second IDH oral inhibitor that we have for patients with IDH1 mutant disease, and this is what we call a second-generation inhibitor, which in early studies, pivotal studies here, had been approved based on its ability to induce sustained duration of responses in patients with relapsed and refractory disease. And this was a 5-year follow-up of that original trial looking at the efficacy and safety of olutasidenib. As you can see here, the overall response was 48% of patients with IDH1 mutant disease had some response, with patients receiving a CR/CRh having a median overall survival at 5-year follow-up that was not reached. Other responders had a survival of over a year, and this compares very favorably to patients who did not respond, who had a median survival of only a few months. There were no new adverse events noted, particularly no increase in hepatotoxicity and differentiation syndrome, QTc prolongation. And the median overall survival in all the responding patients was a really impressive 31 months, meaning these patients would be expected to live up to 3 years. And I think this would potentially be a new standard for this patient population. Of note, many of these patients were treated prior to initiation or adoption of ven-aza-based therapy. So it was encouraging to see data on a subset of patients, 12 patients here, who had been treated upfront with venetoclax-based therapy and still had about 1/3 of these patients responding to IDH inhibition following venetoclax therapy. And again, this is very important information because if you add on the survival with ven-aza and then you add on the survival with olutasidenib, I think is how you say it, you can then have patients living more than a few years after their diagnosis of AML. We also saw that patients who had AML with MDS-related changes who were not able to go on to allogeneic stem cell transplantation could have their survival prolonged with the use of oral azacitidine maintenance. As you can see here, overall, patients with AML arising out of prior MDS or therapy-related MDS tend to have a worse overall survival. But when censored for transplant, you can see that there was a significant benefit to oral azacitidine maintenance, even in these patients who are not able to proceed to transplant. So again, this is advocating for the use of more and more of these oral agents to prolong survival. Lastly, we ended with a whole session at EHA devoted to a potential new targeted therapy for patients with acute myeloid leukemia, and this is this class of agents called menin inhibitors. Now, menin inhibitors are potentially active in two biological subsets of acute myeloid leukemia for which we previously had no specific targeted therapy. And these are patients that were previously known as mixed lineage leukemia or KMT2A rearranged gene rearrangements. This represents only about 5 or 10% of patients with newly diagnosed AML, but this tends to be a subset of individuals that have only intermediate prognosis following intensive chemotherapy, and in the relapsed refractory setting have pretty dismal outcomes. We also see here NPM1 mutant AML, which constitutes about a third of newly diagnosed AMLs, and can have, again, favorable responses in the absence of FLT3 mutation to intensive chemotherapy. But again, in the relapsed refractory setting, has been absent any targeted therapeutics to date. Both of these subsets are ruled by underlying biology, which is linked to a master epigenomic transcriptome complex, KMT2 rearranged epigenomic complex. And there is a binding site for this complex with the menin protein. And the menin protein activation is essential to the activation of this transcriptionally activated complex that leads to upregulation of leukemogenic genes, HOXA9 and MEIS1, that leads to leukemia and differentiation block. By inhibiting menin from binding to this complex, you turn off this transcription activity. And so these transcription genes are not activated, and this leads to release of the myeloid differentiation block and cell death. And so there are many of these menin inhibitors currently in development. You can see in here some of the names that we talked about, revumenin, ziftomenib, and there were 4 abstracts presented, and I'll just quickly summarize the data with each of them. The most advanced menin inhibitor in development is this drug, revumenin, and there was results from a pivotal top-line phase 2 study examining the efficacy and safety of revumenin for treatment of patients with KMT rearranged acute leukemias. And this involved 57 patients and the median age of 34. These patients had received a median of 3 prior therapies, and many of them had prior allogeneic stem cell transplantation, as well as venetoclax. As you can see here, CR/CRh rates are about 23%, with up to 60% of patients having some clinical benefit from treatment with this drug. There were side effects associated with the drug, specifically differentiation syndrome, as well as QTc prolongation, but none of these toxicities led to drug interruption or dose reduction. And you can see there was significant benefit from this agent. The median overall survival of agents treated with monotherapy was 8 months, with about 39% of patients able to proceed to allogeneic stem cell transplantation. Similar results were seen with a newer menin inhibitor, the DSP-5336 drug. And this drug, in contrast to revumenin, reported very low rates of differentiation syndrome and no QTc prolongation, no dose-limiting toxicities, and again was something that looks to potentially be a newer generation, potentially menin inhibitor. Again, very similar overall clinical response rate, 67%, with CR/CRh rates seen in a third of patients. And so the fact that we are seeing similar biology, similar rates of response, different toxicity profiles suggests that these menin inhibitors are similarly active in treatment of this disease. Now, these low response rates, though, are not going to make anybody excited. A 20 to to 30% response with monotherapy. So there were 2 trials that examined combination therapy of this drug, of these menin inhibitors in combination with ven-aza. There's a third menin inhibitor, bleximenib, and they presented data looking at the combination of patients that got venetoclax azacitidine plus a menin inhibitor. Was relatively well tolerated. There was no QTc long prolongation, very little evidence of differentiation syndrome or tumor lysis. And there were evidence of responses in these patients. Overall, the response rates were 79% of patients, with 62% of patients having some response greater than partial response, and 90% response rate in NPM1 mutant patients. So again, this combination looks to be highly active. You can see overall in the relapsed refractory setting, now we're getting CR/CRh rates almost 20 rather than 20%. We're seeing about 40% CR/CRh rates with this combination therapy. Again, pretty well tolerated. There's another study, the Beat AML study, presented similar data with that revumenib, that first compound, again showing that this was well tolerated, very few evidence of toxicities, and again, extremely high in each of these dose escalation cohorts. Overall CR/CR rates now approaching 60 to even 80% rates with this combination. So this is something that we will need to keep an eye on moving forward. So just some just summaries of key takeaways. Again, FLT3-mutant, very high response rates in younger patients, median age of 44, ideal for patients with favorable intermediate risk who are undergoing allo and CR1, but not for patients that have T53 or MECOM aberrations. The oral decitabine, cedazuridine, venetoclax, and gilteritinib is a very promising all-oral triplet with almost 100% overall response rates, but we still need to be careful because of the prolonged cytopenias and potential for sepsis. Patients who have AML, MRC, getting intensive chemotherapy, who are not able to undergo allogeneic stem cell transplantation can have their outcomes improved by engaging in oral azacitidine maintenance. And for older unfit patients, consideration of more truncated venetoclax-based regimens for these patients may be something that we would like to pursue in patients who are not NPM1, IDH1, IDH2 mutant, and particularly for patients, for example, P53 mutant patients who might not necessarily need 28 days of venetoclax as part of upfront therapy. Incorporation of palliative care discussions may be important, and olutasidenib for mutant IDH1 as well as menin inhibitors look very promising for the treatment of specific subsets of relapsed and refractory AML. So I'd like to just end by just taking some questions from the audience as well as my peers. Let's see. Do you foresee that community oncologists will be able to use these agents as outpatient therapy similar to ven? Yes, I do anticipate that as these regimens are showing efficacy for oral targeted therapy, that these therapies will most likely be adopted by community oncologists in the outpatient setting to treat patients and will allow these patients, particularly those that live at a distance from major medical cancer centers, to get similar outcomes as what we would do in our major centers. In the FLT3-mutant trial, how many went on to receive allo transplantation? And so maybe Courtney could address that because she was actually the senior author of that abstract at EHA.
Yes. Most patients go on to transplant. So I'll just, if I can, just take a second to talk about FLT3-mutant and just highlight the fact that this is a very effective, but also very intense regimen. And so I get asked a lot, is this something that we should be using in the community? And I think it really just depends on the level of resources that you have, because we see a composite remission rate of greater than 90% in the frontline setting, and 80% of people are MRD negative. So it's really quite impressive, but people can get sick, can get bacteremic and have nephritis and issues during the nadir. Not everyone, of course, but it can happen. So you just need to have that ability to be monitoring people like 3 or 4 times a week, rapid, they're nearby, so you can admit them for antibiotics if needed. They need a lot of transfusion support. The people that benefit the most, are the intermediate and the adverse risk patients who don't benefit as much from intensive chemo. So there's just more of a bar of a delta of improvement. And almost all of those patients in the frontline setting went to transplant. And so the median number of cycles was only 2 because the vast majority of people went to transplant successfully.
Thank you, Dr. Wang and Dr. Dinardo, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Congress to Clinic Myeloid Malignancies Clinical Advances Journal Club on emerging MPN, MDS, and AML data, and to download the slide set associated with this discussion, please click the link in the show notes. As always, thanks for listening.